So where do you think that you would listen to heart rate?
Heart rate.
So, yeah. Apical, right? And where else can I feel for heart rate? Can I feel the wrist for a baby? Brachial, good. So you just want to make sure that you know those two places. But we're going to listen to heart rate for a solid minute. So 1 full minute you have to do that. And it's because it's really fast. And it's kind of like a, but that goes really, really fast. Okay, so I can't hardly tap as fast as it goes. So normal heart rate is going to be anywhere from about 110 to 160. 110, usually the baby's pretty calm or they just have a lower resting heart rate. So I'm going to listen to that. I want to check my brachials. I want to check on both sides, make sure that I have good pulses. And then I'm going to take temperature. And so we take baby's temperatures axillary, okay? There's no reason to take them rectally. We're going to teach our parents there's no reason to take it rectally. It just can damage tissue, especially for individuals that aren't accustomed to doing that, okay? So that's also very important. Respiratory rate is very difficult to get. You're going to listen at first. Of course, you're listening for lung sounds, bowel sounds, and heart sounds, so we're always listening for that. But lung sounds oftentimes are not as audible on an infant as they are on an adult. So you can do one of a couple things. And so I let my students also do it by hand placement. So my baby's laying here, and if I lay my hand across the baby is a belly breather at this point. They're not chest breathers. So with my hand across there, I can usually feel as the belly rises between these two areas of my hand. Oftentimes, sometimes right in here. So you can do them one of two ways. You can try to listen. You've got good lung sounds. You can count them that way. Or you can lay your hand across the baby's tummy and do it that way. So belly breathers, remember that, okay? After I've done all my vital signs and I'm looking over skin color, that's really important as well, then I want to keep my baby kind of covered as much as possible while I do my assessment. You don't want this baby to get too cold too quickly, okay? So very important, especially depending on the size of the infant. That's very important. I always start off with my babies on the head, and so I usually set them upright. This baby's a little stiffer, but I usually rub my hands around on the baby's head to just kind of feel for symmetry. And so what I'm doing right here is just determining, you know, is this baby got molding, or is this a nice round symmetrical head? Remember that molding occurs because the baby comes out of the birth canal, so I'm looking for that as well. The next thing I'm doing with the head is making sure that I don't see any electrode marks, and so sometimes these babies are monitored in utero by an electrode that tells heart rate very accurately. So if a baby is what we call kind of crashing and burning, or maybe not doing well, or they're not able to hear it as well as they would like to, or monitor it as well, need a little closer monitoring, they're actually going to take an electrode, and it does screw in. I know that sounds cruel. It just goes into the top layer of that skin, and it just gives us a better reading on the heart rate. And so you might see one of those as well. Of course, you're looking for any other abrasions, any scratches, if they used a vacuum to pull the baby out, or is there bruising associated with that? That bruising could be on the scalp, it could be around in the face area, it could pretty much be all over. It just depends on where the doctor grabs the baby from, okay? So you're looking for any of those. Then I'm going to check for fontanelle, so I'm going to run my fingers across the baby's suture lines. You're going to feel a set this way and a set this way. I'm going to feel across there, and I'm going to feel for this soft spot is basically how you'll probably know that. I'm going to feel for the anterior fontanelle and then the posterior fontanelle. The anterior one is more diamond shaped, a little bit larger. The posterior one is going to be more triangular shaped and a lot smaller. So I'll help you, Mindy will help as you guys run your hands across the babies to determine that. We're also looking at the suture lines. Sometimes the suture lines are overriding, sometimes they're slightly separated. And so remember, this baby's head has to come out of this opening. And so the head actually, the bones of the head actually have to cross sometimes to get that baby's head out. Sometimes the baby's head is very small and there might be a slight separation between, and if you lay your finger kind of in between your two fingers here, you'll kind of feel what that separation would feel like. Once I've looked at that, I'm going to lay my baby back down. I'm going to look basically at the face. You don't have to pry these babies' eyes open. You can cause a lot of damage as you go to pry eyes and things open. If you turn down lights, babies will often open up their eyes, and so that's a really good way to kind of look in the eyes. You can also see if there's any drainage, any major drainage or crusting, just by looking at your baby, even if their eyes are shut. Okay, so you can kind of see that. So I'm looking for any of that drainage, goopiness, anything like that. Next, I'm looking at the patency of the nares, and so I'm going to place one finger over one side, and I'll watch the other side flare. Then I'll place my finger over the other and watch that side flare. So you're looking for that patency. So I want to make sure that this baby has two patent airway nares. So I want to make sure that both of them are patent, and that the septum is not deviated to one side or the other, okay? Because that could be very important for breathing, down the road and things like that. Next, I'm going to look in the mouth. Let the baby cry. That's a really good time to look into the baby's mouth. I'm looking for a variety of things. So I'm looking for, of course, any kind of buildup on the tongue where the baby could possibly have like a thrush type of situation going on. Mothers that breastfeed will pass that back and forth from baby to breast and breast back to baby, so it's something that we need to monitor. So you're looking for that. You're also looking to see if the baby's tongue-tied, and what that means is that that frenulum comes to the tip of their tongue, or how much to the tip of that tongue does it come. If you have a frenulum that comes to the tip, or you're tongue-tied, can't get that tongue out of the mouth, okay? And so babies, in order to latch onto the breast, have to be able to get their tongue out and surround. So it's kind of like if you think about a sucker or a lollipop that you would place in your mouth. So they have to be able to get their tongue out to do that. Some babies do okay and can still breastfeed with that, so we will definitely monitor those infants, see how well their suck and swallow is when they get to the breast. Other babies actually have to be clipped, and sometimes they will do that right there at the hospital and clip those frenulums. I'm also looking for any Epstein pearls or just any little sebaceous cyst that might be located in the mouth or anything abnormal. When you look at a baby, you're also looking at symmetry. So I want the eyes to be equal. I want the nose to be in the center of the face. I don't want it to be smashed. I want the mouth to be equal. I want both sides of the mouth to be drawn up in the same direction. If you've got drooping on one side, you might be thinking stroke or perhaps a palsy of some sort as the baby was delivered and nerves were damaged. And so I'm looking at those things as well. Excessive drooling and things like that. When I look at the ears, I want to look to see that the ears are well formed, that they're on the outside of the head, that you can see a very, that the ear looks very normal. And I also want to check that positioning. If those ears are low set, in other words, if I can draw an imaginary line from the top of the ear over to the eye, it should not sit lower than the outer part of that eye canthus. So if it does that, then there's what we call, a lot of times you'll hear the term FLK. It's a real term. It does stand for funny looking kid. But it's important that you look at those kinds of things because that is an abnormality. So is this a Down syndrome baby? And that might be one thing that we're looking at. Also, it's important that when you look at these kids and you see something abnormal is that you don't immediately go, oh my gosh, something's wrong with this kid. We really need to go back to the parents and look at the parents. And a lot of times we will say, oh, you know, that individual has low set ears, or that individual has, you know, whatever is going on in the child. So it's very important that we're looking at all of those pieces together, okay? Once I've looked at the face, and of course always I'm looking at skin color, so I'm making sure that that the blood is flowing where the blood needs to flow. And remember that as the heart valves are closing, as the baby comes into the extrauterine world, we are looking to make sure that the baby's being oxygenated correctly. So you might see the baby's hands and feet be a little bit blue. That's okay, but we want to make sure that the trunk and the body is nice and pink. The body is saying, hey, I've got to feed the organs the oxygen that I need. Hands and feet are okay, but let's get to them in a little bit when we've got all this working correctly. So that's kind of how that looks. The next things that I'm going to do is to look at the chest. You want to check nipple, breast buds. You want to be able to feel them, and you actually just take your little fingers and you kind of feel around them. You'll learn in your text like about what size that they should be. I always give an example that on a female pinky finger, it's kind of that lower portion of the pinky finger, so if that's what that feels like. Little boys can be born with breast buds as well. Daddies get extremely alarmed by this. You just need to explain to them that it's hormonal related and that will go away and the breast will flatten basically in the next couple days. So, but dads get very nervous. Why does my little boy have breasts? He doesn't. It's just hormonal related. So we're looking at that. I'm going to work my way down looking at the umbilical cord. Want to make sure that that's nice and drying and that it's been clamped, okay? At this point, it's probably very difficult to see whether it's a 2-vessel or a 3-vessel cord. You'll hear about that in report, and you'll talk about a lot about that in class, and I'll talk about it in clinical. What does that mean if there's only 2 vessels? So I'm going to be looking at that. We can't unclamp those cords once that starts to dry, and that's dry all the way around the edges. Otherwise, we're just going to educate. No longer do we have to put alcohol on those sites or even triple dye them, which is, they used to be colored blue, and that was an antibiotic plus a drying agent. We no longer use that, okay? Work my way down to the genitalia. If it's a little girl, I just want to make sure that the labia majora covers the labia minora and the clitoris. If not, it just is a part of what we would determine of gestational age, or looking at a Ballard scale and gestational age of the child. So basically, how does the baby present based off of how are the dates that the mother presented with. So in other words, it's a 38-week baby, but it presents like a 36-week baby. There's a difference. Does that make sense? Or does it present like the dates show as 38? So that's what we're looking at there. If it's a little boy, you want to be sure that we're checking testes. Have the testes, we want to check to see that the testes have distended into the scrotal sac. We'll both show you how to do that on clinical site. You're looking at the rugae, or the little old man wrinkles that are on the scrotal sac, okay? And that's important too, again, based off of gestational age and what we're looking for. You're looking at the penis to make sure that that the meatus is at the tip and at the opening there, that it's not on top of or below, because that makes a difference in whether we'll circumcise these children in the beginning or not, okay? And so again, you'll learn more about that in class. Working my way down to the feet, I'm looking to make sure that we have 5 fingers, 5 toes on both upper and lower extremities, so I want to make sure that I have all my parts that I'm supposed to have, okay? So we're looking at that as well. I'm going to flip my baby over, and I'm going to look at the back. And so at this point, this baby is kind of dangling. This is a stiff baby, but she would normally be dangling here. I'm going to run my finger down the spine to make sure that that spine is nice and straight. I'm going to pull back the diaper to look for at the base of the spine to make sure that it's intact. And so I don't want to see a dimple and or a tuft of hair. And so those two signs can indicate, doesn't have to be, but could indicate either a tethered type cord or it could be an incomplete spinal development at the base of the cord. If you see that, sometimes it's called spina bifida occulta or oculata. Is it occulta?
I call it occulta, but you will learn that I have horrible pronunciation.
Yeah, some people call it oculata. It's spelled that way, but it's occulta. That's an internal spinal bifida. Usually these children are not paralyzed. They usually can walk. In fact, about 7% of the population actually has that and doesn't know it, okay? I myself am one of those individuals, didn't find out about it until I was 21 years, and it was only because they did surgery. So had no idea. So doesn't affect everybody, but it is quite prominent in the population. If it is opened, then there is a protrusion. That's a meningocele, and that's a totally different ballgame. Those children are generally paralyzed. You will not see them at Clark or at Floyd. They will be sent over to Norton Children's Hospital, okay? But that's what you're looking for there. You'll also look to see if there's Mongolian spotting, that darkened spot that they've said in ethnicity backgrounds. You will see that. Usually you see it on the buttock area. You might see that on the back, occasionally on a leg, but you generally see that back here in this area, okay? So you're looking at that. You want to make sure that the anus is patent. You'll tell that very quickly when that baby has a good poop, so you know that the anus is patent as well. And the same thing with being able to urinate, so as soon as we see a good pee. That's very important to have those things occur within that first 24 hours where a physician needs to be notified, okay? Anything I left off on assessment? Good? Okay, so the next things that I'm going to do, especially with my group, is we're going to look at those reflexes and how they describe them on here. And so we can elicit many of those things. And so your paperwork defines many of those different reflexes. And again, this helps to determine and tell us gestational age of the baby, or how that baby actually presented based off of those gestational age. So the first one I'm going to talk to you about is Babinski. And so you're going to take your finger and run that up the baby's foot. And as you do, that baby should flare, okay? An adult will tuck or flex, and an infant will extend, okay? And so I should be able to see that very quickly. If you lay your finger at the tip of the baby's foot, where the toes meet, the baby will grasp your finger. And so that's plantar reflex. I can do that same thing in the hand, which is a palmar reflex, okay? So we're doing that. I like to talk to dads and involve dads in this process and say, you know, right now this is a reflex, but in about 3 months of age, that baby will reach out and purposefully grab at your hand. And so dads like to kind of hear that and be involved in some of these things as well. Other reflexes are going to be, I can stroke the side of the baby's cheek, and that baby will root, so it will turn towards that, looking for hopefully a breast. So you'll be able to elicit that. You won't do the swallow as much unless you've got a mom that has milk production pretty quickly, because you generally can't hear that when a mother breastfeeds until that milk has come in a little bit more significantly. It takes about 72 hours for her milk to come in, so sometimes that's hard to hear, but you can try that reflex. There is step reflex, which if you hold your baby up underneath the arms like this, set the little feet down to the tip of the bed, the baby will actually step. So one foot will lift, and then the baby will put that down and kind of lift the other foot as if it was stepping. Babies actually will attempt to crawl. If you laid this baby prone and gave it a few seconds, it will actually attempt to move its legs and arms as if it was crawling. It's really neat how kangaroo care has been really incorporated into our daily care. And the evidence behind it is incredible what it does for the babies. But if we would leave these kids alone, and as nurses, we just can't do that. When they're born, we want them and check them all out. But if we would just bring that baby out, lay it on the low portion of that mother's belly, that baby will actually crawl up the mother's chest and find the breast all on its own. It's incredible what nature does, but it takes time for that to occur, which we as nurses don't feel like we have that time, and so we kind of interrupt that process. But the great thing is that we're getting very comfortable with that kangaroo care and placing these babies immediately to chest and allowing nature to kind of take its course there. Another really cool reflex is called the Gallant, and so if you lay that baby back on this position, so when I'm checking out the baby's back, looking also for any kind of birthmarks that might be obvious here. As I have the baby here, if I kind of tickle down the side of the chest or down the side of the abdomen, that baby's hips will turn in that direction. So if I pull on down this side, that baby kind of wiggles. So the baby does a little dance. Dads think that's super cute. They like to be involved in that, so I always show mom and dad that piece too. What other reflex? Give me another one. Tonic neck. Tonic neck is another reflex. Baby's laying in the supine position, and if you turn that baby's head to one side, the side that you turn that head to, that baby will flex and the other side will extend. Turn the head back that way, it will flex this side and extend this side. Again, another reflex that helps us to determine. Some of the other things on your sheet are things that are actual physical, where we're going to able to tie a number to it so that we can actually score these babies and say this baby presents like a 36-week-old. And that has to do with the fine hair, whether it has lanugo or not. It has to do with the amount of vernix or the cheesy stuff that you see on babies. It also has to do with positioning of babies. So like there's several things that you can do. So for example, a scarf sign is to be able to take the baby's thumb and it lays flat against the arm. That's a sign of more maturity of the baby. A premature baby cannot do that. So a premature baby looks a whole lot more like what I'm doing now. This is as far as I can go. So a term baby, that lays completely flat on scarf sign. There's also an arm sign where you can take this, it's called scarf, and you move this baby's hand, you leave them supine, move this baby's hand across, and it's where does that elbow end up. So as you move this across the baby's kind of neck area, and that should end up straight here dead in the middle, okay? There's also some leg ones that you can do, so it's called heel to ear, and so basically keeping the baby's hip down, lifting that heel up, and how far does it go up to that baby's head in that position, and then a popliteal angle in which I'm looking at the knee angle and what kind of degree does that show when I, again, leave that baby's hip on the ground. So we'll show you that with a real baby. This one doesn't move enough for me to really give you a good enough feel for what that looks like. So we'll show you with that on a real baby. Any questions? It's pretty easy and pretty quick. It takes us a lot longer to talk you through it.